Good evening, everybody, and thank you so much for joining us tonight for our webinar. My name is Karen Lee, and I'll be your host. This webinar is brought to you by the National Keratoconus Foundation. They are an outreach program of the Gavin Herbert Eye Institute at UC Irvine, and really they're just dedicated to increasing awareness and understanding of keratoconus, and they just want to provide resources to patients out there that are suffering with this debilitating condition. Tonight, we're really excited to welcome Dr. Susan Resnick on her topic, yes, there are soft lenses for keratoconus. This is probably the #1 most common question we get in clinic every time we see a patient. And I'm so excited to listen to her to speak about this because she is president and managing partner for an eye care practice with offices in New York City and Long Island. She is a graduate of the New York State College of Optometry. She's also a diplomate of the cornea and contact lens section of the American Academy of Optometry and a fellow of the Scleral Lens Education Society and the American Board of Optometry. She's also editor-in-chief of the journal Clinical and Refractive Optometry. In 2022, the American Optometric Association Cornea and Contact Lens section actually presented her with the Luminary Award. She's an author, a lecturer, consults for many different companies, and she's a mentor to many of us. And she's incredibly keen and interested in helping patients with keratoconus achieve the best vision possible. So take it away, Dr. Resnick.
Thank you so much, Dr. Lee, and thank you to the National Keratoconus Foundation for the privilege of speaking with everybody this evening. So I decided to give a talk on a subject which is not often discussed regarding the management of keratoconus. The ophthalmic industry has been so incredibly focused on scleral lenses over the past several years that alternative and still very useful modalities often can be overlooked. So everybody has to listen tonight taking this with a grain of salt because this is kind of a neat topic and soft lenses are not for everybody, but my goal is to present to you the conditions under which I would consider soft lenses for a patient and where they might fit in to our lives for those of us with keratoconus. And as I was discussing earlier with Dr. Lee, you know, soft lenses and rigid lenses are not mutually exclusive. I have many patients who would maybe wear their rigid lens for certain times and then switch to a soft lens for certain occasions or certain times of the day. And so, for example, when I get referrals from corneal specialists, the patient usually always comes in telling me they need to be fit with a rigid lens or a scleral lens or a hard lens. And the first thing I say to them is, I appreciate your doctor sending you, and I respect their input, but let's not assume anything until we look at all the factors. So that's what I want to leave you with as an intro to tonight's discussion. So here's a brief look at what I'm going to be covering tonight. We're going to take a look at how do soft lenses compare to other lens designs? In other words, how effective are they and what's the difference between a soft lens and a rigid lens? What are the clinical criteria for selecting soft lenses? What are soft lenses made of and how do they correct for keratoconus blur? Also, some of you may have had previous corneal surgery or are considering corneal surgery. How do the various corneal surgeries impact soft lens fitting? We'll talk a little bit about the pre-fitting exam, the actual fitting process, what the doctor is looking for, and a little bit about the care of lenses. And then finally, we're going to take a quick look at what the future of soft lens technology might have to offer. So let's start with what are the benefits of soft lenses. The first thing that comes to mind, especially for patients that are newly diagnosed or have been in soft lenses before, is familiarity. They're in soft lenses, they've enjoyed wearing them, they're comfortable, and all of a sudden they're diagnosed with this pretty scary disease. And so they're very nervous about all the things that they look up online that Dr. Google scares them with. But we want everybody to stay calm and understand that this is a disease that is very easily managed and often can be managed with soft lenses in the beginning. So there's a feeling of normalcy. They're not feeling suddenly, oh my God, my whole life is changing. And for these people, there's also nothing new to learn with regard to handling the lenses. Often less adaptation is required for soft lenses, although When we get into some of the customizations later, there can be a little bit of a physical difference in the way they feel, because as I'll be explaining, these lenses are a little bit thicker in design. These lenses offer us the opportunity, offer patients the opportunity to switch more easily between glasses and contacts, because you don't get some of that spectacle blur. And for those of you who have not heard that term, that's when your rigid lenses come off, whether it's a small gas particle or even a scleral lens for that matter. There's a period through which your vision, even as poor as it may be through your glasses, can actually take a little longer to come into focus. And finally, soft lenses may be more conducive to part-time wear. So for patients who are able to wear glasses and achieve good vision and want to be able to go back and forth, soft lenses are actually an excellent option. So let's take a little bit of a dive into the clinical aspects here. I want to just share with you an explanation of what's different between an eye with regular astigmatism, that is normal astigmatism, and a keratoconic eye. So here on the left, you can see a topography, and this is regular astigmatism. And what we mean by that is that the image takes the shape of a nice figure 8. We have a nice symmetry. If we were to draw a line through the center of the picture, a horizontal line, we can see that we have equal steepening above and below that horizontal line. Now down below, I have a chart, and I've highlighted in red, and these are the corneal curvature measurements in diopters. And this is normal astigmatism, where you'll have roughly about 3,600 up until about 4,700 an either meridian. And that's steepness, the higher number being the steeper value. You can see going up above that, the maximum keratometry in a normal cornea is generally coming in at about 47.5 diopters. Now let's jump over to the right side of your screen. Looking up at that topography on the right, you can see how we do not have that symmetry of that figure 8. On top, we have that blue area, which shows us that that area is much flatter than the steeper red, which is visualize it coming out. So you do not have that symmetry around that horizontal meridian. If we look at the curvature values, and this is a breakdown of where we gauge keratoconus or how we classify it, mild, moderate, and advanced, you can see that mild keratoconus may be often similar to normal corneal astigmatism or curvature in that 4,700 range. But as we continue to get steeper, the keratoconus is more advanced. And severe keratoconus, we're going to have corneal curvatures greater than 62 diopters. So when we're talking about soft lenses tonight, we're going to be breaking it down into conventional soft lenses and custom soft lenses. And we're going to be talking about which of those is applicable to our keratoconus population. And this is where these pictures and these numbers come into play, because the closer your cornea looks to the image on the left and the values on the left, the more suitable soft lenses will be for you than the image and the values on the right. So here's another, I'll use the word crude depiction. What's interesting is that this is an image that shows uncorrected astigmatism versus corrected astigmatism. And the truth is that blur is blur. Your brain can't tell whether your blur is due to astigmatism or just high myopia or high hyperopia, but this just gives you a little bit of a kind of a recognition, which most of you probably already have if you have keratoconus. When your vision is uncorrected, you're going to see that blur, lights will be scattered. When it's corrected, everything comes to a point focus. But what I really wanted to point out here is the difference between regular and irregular astigmatism. Now, we talked about that in the previous slide where we looked at the topography, but this actually depicts how the rays of light would be reflected or refracted depending upon the corneal shape. So if you look here on the left, no astigmatism, you can see a nice even pattern to both the lines that go horizontally and the lines that go vertically. And while there's curvature, each of the squares has essentially the same volume or the same area. When we look at regular astigmatism, just like before, we can see that the lines going horizontally are evenly spaced, even though their spacing is different from the lines going vertically. But the vertical lines also have even spaces. But take a look at the last image on the right, and this is irregular astigmatism, and we can see that there is randomness to the way the pattern is. You have some horizontal lines being fatter than the vertical lines. You do not have even spacing. So this basically just is kind of a graphic to drive home what we're going to be looking for when we do our evaluation of whether we're a candidate for soft lenses. So I mentioned to you that there are two routes you can take, your doctor can take, when deciding if a soft lens is going to be, work for you. And you have conventional soft lenses versus custom soft lenses. We're going to use the word conventional to mean lenses that are pretty much on the shelf, that your doctor has been fitting you with perhaps before you develop keratoconus, or your friends with normal corneas wear, where they're available as daily disposables, or maybe every 2 weeks or monthly. They come in those little blister packs, and you basically can order them from a variety of sources. So a standard or conventional lens will be used for patients with acceptable spectacle correction. And also if eyeglasses and contact lenses can or want to be worn interchangeably. They can be used for patients with corneas that are not too steep. We talked about that classification of the lower values being more normal, the higher values being more advanced. And again, these are often available as single replacement daily disposable blister packs. The majority of the discussion tonight, however, is going to talk about custom design, because these are the lenses that we're going to use for patients with higher levels of astigmatism or greater corneal irregularity. For patients with steeper corneas who need a tighter fit, these are available as vialed products, and you can have them ordered anywhere from a monthly to a quarterly to an annual replacement. And the beauty of these lenses is that your doctor doesn't have to fit your eye to the lens, but can fit the lens to your eye. Pretty much every single parameter of these lenses is customizable, and we're going to talk about that in just a moment. So how do soft lenses compare to rigid or hybrid lenses? So typically they're, in certain cases, easier to fit. And that's mostly because a lot of doctors are just more comfortable. They've learned fitting soft lenses, they've had more experience in school, or certainly more patients wear soft lenses. It's not to say that there isn't some complexity to fitting a soft custom lens, and we'll talk about that in a minute or two. But certainly for most doctors, they are a little bit easier to fit. These lenses, as I mentioned, are replaced with greater frequency. They're indicated for less advanced keratoconus, and the vision may not be as acute. So that's something you have to think about if you are discussing this with your doctor. Many times your candidacy for a soft lens really depends on how fussy you are. If you have comfort problems with any of the other modalities and it's limiting your wear, are you willing to sacrifice a line of vision to be able to wear the lens throughout the day? And that's something that's different for each of us. Each of us has, different sensitivities. They may not be as good for dry eyes either. Rigid lenses usually are better for patients with tear film deficiency. Certainly sclerals, as we know, because they hold a reservoir of fluid, are often used for severe dry eye. So I would not pretend or promote these lenses for extreme dry eyes. But for mild to moderate dry eyes where comfort's a problem with other lenses, they certainly work very well. And in certain cases, these may be less costly in terms of having spare lenses. So here's a slide I actually took from a lecture I do for doctors, and I just thought it would be a nice way to kind of summarize for you how I go about what my nomogram is and matching the cornea to the kind of lens that I would select. So on the left, you can see here I have a list of corneal conditions. And on the right, I have the different ways that we can correct keratoconus. So we talked about custom soft, and as you know, there's corneal GP lenses. Those lenses are typically smaller than the actual diameter of the cornea. Intralimbal would be a little bit larger, approaching the full diameter of the cornea. Then you have hybrids, as you know, which are a combination with a rigid center and a soft lens skirt. And some of you may be doing very well with piggybacks, where you have some soft, high oxygen permeable lenses cushioning your small rigid lenses, which is still an excellent option. So if we now just focus on the custom soft, because that's a discussion for tonight, let's take a look and see what boxes we can check off. So I have green being a go, and I have yellow being proceed with caution. So the custom soft will work well for corneas with low to moderate irregularity, where the apex, which is the steepest part of the cornea, is fairly well centered. And tolerance for these lenses is usually excellent. So if there are comfort issues, these usually will fit the bill. But they can also do very well for patients with decentered apexes, if the cornea is not otherwise too irregular. And custom soft lenses and soft lenses in general work well if you have issues with your sclera or your conjunctiva. So patients with pterygium or pinguecula, which are lumps and bumps on the white part of the eye, often can do very well. Or if you've had previous glaucoma surgery and we don't want to put pressure over the incision site. So these are the things that will also guide your doctor in determining whether you're a candidate for a soft lens. So let's just review what the standard soft lens correction criteria would be. And remember, that's the lens that's kind of the off-the-shelf mainstream lens that you might have worn for years and that your friends wear. So just to review, these lenses are soft lenses will have limited effectiveness for the irregular cornea patient, and their best application is in mild cases of irregularity where the topography is symmetrical centrally and there's minimum optical distortion and there's adequate vision achievable in glasses. The benefits of standard soft lenses outside of patient comfort and cost is that they're readily available in most eye care offices. There are many replacement options and most practitioners have expertise in fitting them. The downside to commercial soft lenses is that they don't correct irregular astigmatism and they may exhibit rotational instability with greater amounts of corneal irregularity. So we're going to talk about rotational stability as being a criteria when you have a lot of astigmatism, which most people with keratoconus do. Those lenses have to be very stable on the eye. Otherwise, it's like taking your glasses and doing this. The lens rotates, so the prescription is never really in the right spot. So for high astigmatism, you have to have a lens that stabilizes very well, and for that, often a custom design works better. And these lenses are good, as I mentioned, are a good option for patients who do not have critical vision needs and want spectacle independence despite still seeing well with eyeglasses. So let's move on to now the custom soft lens selection criteria, which I suspect is the most applicable part of the modality, or most applicable modality for most of you here this evening. So there are an increasing number of lathe cut custom soft lenses that are available to us practitioners and to those of you with irregular astigmatism. And believe it or not, we have more than 18 designs now. Some are available in hydrogel and some silicone hydrogel materials. Custom soft lenses offer better initial comfort, centration, and vision when standard lenses fail. They can be manufactured in virtually any parameter, including steep base curves for patients who need tighter lenses, and almost any conceivable sphere, cylinder, and axis down to a single degree. And the ideal patients for custom lenses are those who have a decrease in best corrected acuity with spectacles and traditional soft toric options with mild to moderate irregular astigmatism. So here's the question I suspect everybody has right now, and that is, am I a candidate? Well, let's talk about that. The one thing we need to know is, what is your level of best corrected vision with eyeglasses? So there's no one answer to this question. In my practice, I basically listen to the patient as they're reading the chart. I watch their facial expressions. I get an idea of how, I'll use the word fussy or visually sensitive they are. But if I had to give you a rule of thumb, I would say that 20/40 or better without a lot of glare or haloing makes the best candidate. That doesn't mean that I don't fit patients who also have 20/50 or 20/60 with increasing glare and haloing. I just express to them or set expectations to be more in the 20/25 correctable range or 20/30 correctable range with custom soft lenses than 20/20. We like to know whether you're going to be switching between contact lenses and eyeglasses. If you are, then certainly soft lenses are an option. Have you failed with other types of lenses due to comfort issues? Certainly then soft lenses are good for either part-time or full-time wear. Not everybody has comfort issues to the point where they can't wear rigid or scleral lenses at all. For some of us, it's okay, you know, it's 6 o'clock at night, I really feel like I have to take them off, but I have to work till 8 or 10 at night, or I don't like or can't get comfortable in my glasses. One good or a good candidate for these lenses is if you only need a lens in one eye. I find that soft lenses for a lot of patients just become a little bit easier to adapt, and they're less aware of having a lens in one eye only. Now, is your cornea free of significant scarring? So you could have a low degree of irregularity and even having low K readings, meaning your curvature isn't that great, but you might still have scarring for one reason or another. And soft lenses generally won't correct well enough if you're scarred. Rigid or scleral lenses will correct better in the presence of scarring. So let's talk a little bit about the architecture of custom soft keratoconic lenses. And they really don't differ from custom soft lenses of any type or regular conventional soft lenses for that matter. But the difference is that all of these parameters are modifiable. And so rather than matching your eye to a prefabricated design, your doctor can specify each parameter to best fit your particular corneal shape and prescription. So the base curve is the central fitting curve, and that's where the power of the lens is. That's in the center of the lens. That's the part that actually fits over the steepest part of your cornea. Then the doctor's going to take a look and measure the diameter, but they will prescribe the diameter based upon the diameter of your cornea. And typically we want 1 millimeter to a millimeter and a half to 2 millimeter overlay to extend beyond the corneal diameter. So let's say your cornea is 12 millimeters. At a minimum, you know, we're going to have about a 14.5 millimeter lens or a 15 millimeter lens. Toric stabilization I spoke about before, and this is what the manufacturer uses to make sure that lenses that are correcting or have high degrees of astigmatism in them stay in a certain position on the eye. Now the lens may malposition a little bit, but as long as the lens is always in the same position, the doctor can compensate optically, mathematically for the prescription. We just don't want the lens doing this. We want it to either sit here and always sit here or sit here. Ideally, everything, the marker is at 6 o'clock or 3 and 9 o'clock, depending on the particular manufacturer. And that's something your doctor will be looking for. So lens thickness is interesting because this is what we're going to be manipulating in a lot of these designs to help mask the irregularity. We're going to talk about that in a few minutes. The lens itself is going to be made thicker over that central area where the apex or the irregularity is, but the lens will rapidly thin through the middle portion and the edge to maintain oxygen flow, and that's critical. And the edge design will be thin, and then we're going to talk about the different materials. But how do custom soft lenses work for keratoconus? How do they actually correct the vision or control the blur? And so as the contact lens thickness is increased over the area of the optic zone, it begins to approach the non-flexing nature of GP lenses. It doesn't eliminate the irregular astigmatism like a GP does. I don't want to imply that it does it as well, but it does convert the irregular astigmatism to be more regular in nature. And the necessary toric lens power can then be placed on the front surface of the contact lens to optimize the vision. So understand that the effect of masking the irregular astigmatism begins at about 0.2 millimeters of thickness. A standard soft lens you can see here is roughly 0.07, and you can see that on the left. Next to it, we have a center thickness of 0.4, which is, about 5 or 6 times thicker. And that's what a custom lens will do. And that's going to be what's going to control for that irregularity. So to understand how much irregular astigmatism the custom soft lens is providing, your doctor may perform keratometry either manually or via corneal topography. And that's the way we measure corneal curvature over the top of the contact lens. And what they do is they analyze the mires reflecting back, the mires they can see either in the device or see during topography. And if significant amounts of corneal irregularity are present, increasing the corneal thickness can help improve the visual acuity and reduce the irregularity. So here's just what I was speaking of before. These are mires. This is taken from the topographer. And for those of you who have obviously been examined, you know what a topographer is. And the first image that the doctor gets is this placido disc image. Essentially, it's a set of equally spaced rings which get reflected off the cornea. Now, the more irregular your cornea is, the more distorted the reflection is, okay? So you can see that in the top 2 pictures, and that's before a soft lens goes on, and you can see it also in the gray pictures on the right, the top being without a lens and the bottom being after a custom lens of a certain thickness is put on the eye. So that's how we gauge how much irregularity we are able to correct with soft lenses. What are soft lenses made of? There are traditional materials and there are silicone hydrogel materials. The traditional materials are lathable materials. They're not as oxygen permeable as silicone lenses, but they offer a lot of benefits in that they are easily laid, they're very comfortable. They are very deposit resistant, and they have excellent optical properties. And for most patients, while the oxygen permeability of these lenses is not as great, it's not really an issue because custom soft lenses are fit to move a little bit more. And the pumping of the tears under the lenses is what delivers the oxygen to the cornea. So I rarely, if ever, have to fit or use silicone hydrogel material, although it is an option. And certainly if I see signs clinically of blood vessel growth, which we call corneal neovascularization, or I'm fitting somebody who's had graft surgery, a corneal transplant, those people often need more oxygen, so I would choose a silicone hydrogel material for those individuals. So what we're going to do now is we're going to get into a little bit of the different surgeries that a lot of us with keratoconus might have. And corneal crosslinking, as you know, has become very widespread in the last few years. And the reason is it's such a wonderful procedure. And the goal is to catch the keratoconus early and go through a crosslinking procedure because it halts progression of keratoconus, of pellucid, and also of ectasia that may have occurred after your LASIK surgery. So crosslinking can reduce the steepness and the aberrations, the loss of best corrected vision, and reduce the need for corneal graft surgery. So think about all of the things I said that makes you a candidate for soft lenses. So if your keratoconus was caught early and you're still achieving good vision and you're not progressing, yes, that's what this is about. Soft lenses may be appropriate for you. How do we decide when we're going to refer somebody for cross-linking? Well, generally we look at them, a baseline, and then we look at them a year later, unless we have evidence or previous records of an increase in astigmatism of greater than a diopter or more than half a diopter of the myopic component, or if their maximum curvature that we talked about before has increased more than a diopter. If you're a current contact lens wearer and you're wearing soft lenses, we're going to ask you to stop wearing your lenses about 2 or 3 days before surgery. And if you're a gas permeable lens wearer, we're going to ask you to stop wearing your lenses about 7 days before surgery. So what actually happens after cross-linking? If you take a look at this little timeline at the bottom, so during the first week, your epithelium is healing, and we're talking about epi-off cross-linking. After the first 1 to 2 months, you might actually get a temporary steepening, and then your cornea continues to heal and it gets modified over the next year or two. So I have patients who continue to get flatter and see better for the first couple of years. But how does this relate to our fitting of the contact lenses or initiating fitting? So with epi off, we have to wait a little bit longer because we want that epithelium to be fully healed. Unhealed epithelium, or at least in the beginning, there can be a decrease in the cells that create the attraction of the cells to the underlying layer. There can be reduced sensitivity. There's essentially like a type of anesthesia that occurs because the nerves haven't regenerated. So we want to be very careful not to create any abrasions that you might not feel, because then you're at risk for infection. So we typically wait for about 3 months to fit post cross-linking for both hard and soft lenses. For patients who have worn lenses before and are well versed in how to put them in and can do so without any trauma, we can fit those patients, sometimes a few weeks to 2 months afterward, but your doctor has to decide that. So we want to do the fitting when the refraction and the topography are stable. However, as I mentioned, you may continue to change over the next 6 to 12 months. So you just have to understand that your doctor is going to want to make changes if you change. And most of the companies that we deal with have a 3-month warranty. So when those first lenses are ordered, we can fit you and then change it up until 3 months. We want to make sure your vision is good with spectacles. You might be able to wear conventional or standard CLs, but if you have ghosting or poor quality vision, we're going to go with a custom soft. And here you can see at the bottom, that's an image of a patient who undergone 1 month level of cross-linking, epithelium off. And you can see that there's haze. And so that haze will continue to dissipate over 3 months. And that's why at first the vision isn't quite as good as it will be at the 3 to 6 month level. So moving on to corneal transplants, can you wear a soft lens after corneal transplant? Well, it depends on several factors. We're going to look at the shape of the graft, and I'm going to show you different images in a minute. The degree of the astigmatism and the irregularity. And again, the more regular and the less astigmatism, the more suited you'll be to soft lens fitting. Suture removal may often be postponed as long as there is no corneal neovascularization or loosening of the sutures. And in the case of early visual rehabilitation, meaning you can't get good enough vision with the glasses, we can fit you with contact lenses placed over those sutures as long as everything looks good and the cornea looks good. And the sutures, the epithelium has to be well healed over those sutures, and that can take 6 to 12 months. Partial suture removal is a technique that many of the doctors use. They take out the interrupted sutures to gradually control for any astigmatism. And you can see there are varying methods of suturing that your surgeon may use, but we can certainly work with soft lenses during that time period. If you have a very oblate cornea where the center part of the cornea is really, really shallow and your host cornea is steep, then likely you will not do well in a soft lens. We typically then have to work with usually a scleral, what's called a reverse geometry lens. So this is just a graphic of different shapes that we sometimes see after corneal transplants. What I did was I put a purple arrow next to the ones where I would expect to need special edge customization due to the steepness of the cornea close to the limbus, which is the edge of the cornea. And for those patients, we're going to do special edge customization. On the left, you can see this astigmatism is fairly regular after the graft. On the right, we have fairly irregular astigmatism post-graft. So again, your doctor is going to analyze your topography very carefully, first determine if you're a candidate for soft lenses, and then determine the level of customization. And how do we customize the lenses? And there's one company, well, actually, many of the companies do it. Bausch & Lomb makes the Novacone, and then there's a lens called Keratoconus you guys may be familiar with. But this can be customized, and this is from the Keratoconus website, the sector management control, where we can actually specify, like we do when we fit scleral lenses, we're able to specify which edge we want tightened up so that the lens doesn't buckle or flute. Because if your corneal cornea is too steep near the edge, that lens can cause a little buckle or fluting, which can make the vision a little stable and also create a little bit of an annoyance, a little bit of a tickle, and have the lens not be as comfortable after the, your surgery. So just to get a little bit into how do we look again at the pre-fitting conditions, we're looking at the severity of the keratoconus, again, mild, moderate, advanced, which we talked about earlier. And then we're going to look at the corneal profile, the position of the apex. And as I talked about before, custom soft lenses generally will work better with apexes that are more centered or not too low lying. We're going to look at peripheral curves, and we're going to look at the size and area of the cone. And this graphic just shows you the different aspects or different types of conditions. We're going to not only look at corneal shape, but we're also going to look at where the highest degree of ectasia is at the apex. And we're also going to consider oxygen requirements in terms of what material we're going to use to make your soft lenses. At the very bottom, you can see that you blue in the center and red in the periphery. And that particular shape we will see in patients who have had refractive surgery, LASIK, who might develop ectasia after, or post-graft, where the suturing is still very tight and that graft is what we call a plateau or a sunken graft. A few years after corneal graft surgery, your cornea is going to start to bulge again, become more prolate. That's just the nature of how the cornea will develop over time. And so sometimes a refitting will occur a few years down the line. And then the final surgery that some of you may have is something called intax, or post or intracorneal ring segments. And what intacs do is they actually lift the cone up, lift the apex up, and they make it smaller. So for patients with intacs, often soft lenses become a very nice option. The cornea sometimes is fairly regular. The astigmatism is limited to the center of the eye. So much as it will often create a better, best corrected spectacle vision, it can make soft lens fitting a little easier. The one issue I have with intacs, and I think a lot of my colleagues would agree, is that unfortunately, the advantages of the intacs are sometimes overshadowed by the fact that there is more ghosting and haloing in certain cases with intacs. So I'm not a big fan of intacs, but certainly in certain cases, they really work well. So when we continue to do your examination, we're not only going to look at the cornea, but we're also going to flip your lid. We want to make sure we don't see a lot of these bumps. If so, that could be an allergy. That would be a concern with fitting a soft lens that would have to be treated. We want to look for corneal scarring, of course, and we want to look at the limbus, which is, as I mentioned before, it's that area where the colored part of the eye and the white part of the eye meet. And that limbus is critical because that's where our baby cells reside, where the cells that become our epithelium reside. So we have to be very respectful of keeping the health of that area. In a grafted eye, we not only have to be respectful of that area, but we also have to be respectful of the graft-host junction where that donor button is sewn onto your cornea. So your doctor is going to be very careful in making sure the lenses drape well and move well. And finally, you can see these little white pimples along the lid margin. That's called meibomian gland plugs. That can be a problem for both soft lens wearers and hard lens wearers, creating filming. So we want to make sure that we get that treated, and your doctor will pay attention to that by giving you hot compresses, sometimes expressing them in the office, maybe prescribing fish oil. There are various ways of improving the health, the quality and quantity of the lipids and the oils. So the fitting goals with a soft lens, the doctor's going to look to make sure that there's just a very light touch with the center of the eye. They're going to make sure that the lens isn't too tight. We don't want it compressing the blood vessels on the sclera and the conjunctiva. We want the lenses to move with the blink, but not excessively so. We want to make sure that the lenses are centered. And certainly, as I talked about, the thickness can be manipulated to control for your corneal irregularity. So one of the tools that I love to use, and I do this a lot when I fit Bausch & Lomb's Novacone lens, because it is thicker and it does have a modulus similar in certain cases to rigid lenses, and we do the same thing when we fit rigid lenses. You may recall your doctor uses that orange dye called fluorescein, and we can actually apply fluorescein onto the eye while the lens is on. and we're able to see the pattern of the lens. And you can see here on the left where you have more glow and a small black spot, and all the way on the right you have less glow and a large black spot. Essentially, we want something in the middle where there's not too much pooling and not too much touching. The touching is that darker area. So we don't want to bear a lot on the central cornea, just a little feather touch, and have good tear exchange as the patient blinks. And we can actually see this. We can see that fluorescein moving. It highlights, it lights up the tears while you're in the chair and we're looking at you with the slit lamp. So that's an excellent tool that we use with this kind of fluorescein that doesn't get absorbed into the lens. So just a little bit of how soft lenses are cared for. Many of you are used to sclerals maybe, or hard lenses. Soft lenses are no different. In certain cases, they might actually be easier. You're going to follow your doctor's instructions, of course. So you can use multi-purpose care solutions. Follow the package directions. It's okay to use an unpreserved saline as a final rinse if you should have any sensitivity. In these thicker designs where I'm specifying thicknesses of 0.2 or 0.3, I always avoid hydrogen peroxide. That's Clear Care. You might be familiar with that. And the reason is that sometimes it gets absorbed into these thicker lenses, and the peroxide doesn't neutralize as well, and patients will have a little bit of stinging when that peroxide is kind of released throughout the day. Using non-preserved lubricating solutions are excellent, and you always want to disinfect your previously worn spare lenses. That's really important. Even though you put them away and they're nice and clean and sterile, you really do need to disinfect them prior to wearing. How often should soft lenses be replaced? The way I do it, because these lenses are not inexpensive and we want to make sure that things are stable, especially if you've had surgery or cross-linking. So I start with the first pair in a finalized prescription, and then I see the patient back about 3 months later, because again, there's a warranty period there. If I have to make a change, I can. At that juncture, I will gauge the condition of the lenses, and that'll tell me, does this patient look like they could last maybe for 6 months or 4 months, or typically not a year. And then I order a second pair, and I have them change the lenses between 3 and 6 months. I look at the patient again at a 6-month level, and then I determine, are they going to be on a quarterly replacement or a semi-annual replacement? But again, every doctor's a little different. So the idea is, though, I think to start with the first pair, get stability, get comfortable, make sure everybody's happy before you order any backup lenses. So to wrap things up, let's just have a little bit of pie in the sky stuff here, looking ahead. And this is happening now with some of the scleral designs, and I know they're working on it with soft lenses as well. So some of you may have heard the term higher order aberrations. So that's if you take a point source of light, and probably you go out on a rainy night, like here on the East Coast, and you look at a light and it's got, you know, you're seeing multiple lights, you're seeing starbursts, you can't really figure out which is the main light. Well, that's higher order aberrations, and even patients without keratoconus have those. But patients with keratoconus have it, you know, on steroids. So the glare and the haloing and the starbursts are caused by different kinds of aberrations, but the most common one in keratoconus is something called coma. And you can see a depiction of that on the right. And so the goal is, how can we correct not just the nearsighted component and not just the astigmatism, because those are considered first and second order aberrations, but how can we control the coma that's present due to corneal irregularity? And even patients with scleral lenses get this. And so there is a way to measure it. It's called an Aberrometer, and you can see that image up here on the left, and it's measured in microns with a technique, something called a root mean square. But basically it means the higher the number, the higher the aberrations. So you can see here on the upper left, that's the eye before a soft lens correcting higher order aberrations goes on. And then you can see there on the right, it went from 3.27 to a little over 1. You can see how much smoother this, or how much more regularly the light is reflected. These lenses are made so that they are customized to fit the back surface of the lens, customized to fit the cornea as we normally do. But what happens is we take that prototype lens and we put it on your eye, and it's got registration marks, which are these little dots you can see around the lens. And that allows the device to register or map where the lens is sitting. And then it takes a measurement of the higher order aberrations coming through the lens on the eye, and then it can be manufactured to correct those higher order aberrations as if the lens were on the eye, and then the final lens is custom designed. And that can increase the vision a line or two, but mostly the quality of the vision is what is vastly improved. So I look forward to fitting these lenses, hopefully within the next year or two. And I think that it's going to be a benefit both for our scleral lens wearers and our soft lens wearers. So I will stop here and I'll turn it over to Dr. Lee and we can maybe entertain some questions.
Thank you for such a great talk, Dr. Resnick. I feel like I learned so much. We had some really good questions from the audience. Probably the most common scenario that we see in clinic is we have patients that come in and they are struggling with their GP contacts. So we have one person in the audience who says that when they wear their GP lenses, they experience dryness and clouding after an hour, which of course makes their lenses difficult to wear, but without their lenses, they can't see. So would this person potentially be a candidate for soft contact lenses?
So of course, without knowing the specifics of the cornea and the things that I discussed earlier, it's hard for me to give an actual answer, for this particular case. But the first thing that has to be considered by their doctor is, was everything done to treat it? The typical cause of that is that meibomian gland dysfunction that I alluded to earlier, where we don't have healthy oils. So the doctors should be looking at that to see whether they need to go on any kind of medication or hot compresses or have the glands expressed to make sure the lenses were hydropegged. There's something called tangible hydropegging, which is a special conditioning or coating that the manufacturer could put on. So I would do everything I could to try to alleviate the problem with the hard lenses. But yes, the answer is soft lenses are more forgiving in cases like this. Yes.
Yeah, and potentially one thing that this person could do to try to test this would be if they take their lenses off and they give it a good cleaning and rubbing and put it back on the eyes, potentially their vision could improve, is my guess as well too.
Absolutely.
Since we kind of touched on HydroPeg for just a moment, we had one person that really wanted to know, and I feel like you did a good job of covering this, but in case they missed this, do our patients have to clean their soft lenses, and what do you recommend?
Yes, so soft lenses need to be cleaned just like rigid lenses. If a multi-purpose solution is used, there's always a rub and rinse directive. So you're going to rub gently. I never like to have rub between two fingers. I always like to have the lens flat, go back and forth on one side and then the other, and then rinse real well and soak for a minimum of 6 hours. And then in the morning, it comes out of the case, rinse with some fresh solution, put the lenses on. The old solution has to be discarded. The case rinsed with hot tap water, air dried, and so just exactly the directions on the box.
In your experience, Dr. Resnick, do you feel like, because we both know how expensive these custom soft lenses can be, do you feel like you have patients that rub and cause their soft lenses to rip or tear?
I don't. So here's the good news. The answer is yes. There's always going to be, a calamity or two. I try to work with patients if they have a problem in terms of working with the manufacturer to see if we can get it covered or discounting. So, that's me. I try to help these patients. But in terms of, is it a real problem? The answer is no. The real problem is not the handling. Sometimes you have to be careful when you screw the case down or close the lid, that you are careful. So sometimes you have to get real close or ask a relative to check the lenses. A trick is to put solution in the case, put the lens in, and then put a few more drops in so you can make sure that lens is all the way at the bottom before you close it.
That's exactly, I 100% agree. If you have a patient and they are fortunate enough to be able to wear soft contact lenses and still see well through them, and they just haven't really progressed to needing GPs or sclerals, in a patient like that, or really any patient, do you feel like cross-linking can actually help the vision slightly, or will it only stop the progression of it getting worse?
I would never promise that it's going to help the vision because that's not what it's for. The answer is it might. I usually will answer the question just like that, but I am still a very big advocate for early intervention, no matter how good the vision is, if I've seen progression.
In New York?
On the contrary, Dr. Lee, you know, you might actually experience a decrease in vision for 6 months after too. Because, you know, the corneal haze. So you have to be prepared to give a little bit for getting a lot, you know, of protection. So in a case like that, I would typically just do the worse eye or the eye that seems to be progressing faster, see what the outcome is, and then gauge whether I'm going to do the other eye.
So for those patients, if they had that surgery done, how long until they can put their soft lenses in again?
So with a soft lens, if it's epi off, which I, you know, talked about before, if the vision's reasonably good in a patient like that, and they're just wearing them because they really want, you know, an option other than glasses, I would wait 3 months. If it's a patient though who's really dependent upon it for vision, for work, for whatever, you know, then and they're experienced wearer, I would say 6 to 8 weeks is fine.
Yeah, I think that waiting period is so critical for that eye to just heal over, especially if we want them to have that long-term visual clarity that they're hoping for.
Right.
So in our patients who are already wearing scleral lenses, and we kind of talked about comorbidities and how our patients can still have dryness. So we have one person in the audience who does wear sclerals and they're still experiencing dry eye even with those lenses on. Is there maybe another option for them? They have reported to have moderate keratoconus.
I'm wondering if that person's ever tried soft lenses, and if they haven't, I would certainly say it's something that could be tried. It sounds like you know, dry eye is it's a short term, but it has long definitions, and you know, it all depends what the reason for the dryness is, and you know, as you know, it could be, there's so many factors. So if prescription drops or lubricants or manipulating the glands aren't really working, and they do have intolerance of the sclerals, I would certainly try soft lenses as an option, even to see whether it's something they can do in terms of alternating between the two. So yes.
What are your thoughts on the filling solutions for this patient?
So always unpreserved filling solution. If we're talking about a scleral, or even a soft lens for that matter, because as I mentioned, some of these soft lenses, you know, begin to feel in terms of the modulus, the thickness, like hard lenses on the finger, although not on the eye. I like unpreserved lubricants in the bowl for either, and you can use unpreserved artificial tears. I just for a rigid lens, a scleral lens, I wouldn't use anything too viscous. I'm sorry, for a soft lens, I wouldn't use anything too viscous. For a rigid lens, you could go a little bit more viscous, but yes, you could do it for either soft or rigid.
Perfect. Thank you so much. I feel like we answered all of our questions out there. And of course, if you all ever, you know, have more questions, feel free to email us. And of course, stay tuned. We have another webinar coming up in March that's going to talk about cataract surgery and keratoconus and how they relate to each other. And instead of having just one amazing speaker, that night we're going to have 3 different speakers working together. And so everybody, I hope you all had a happy holiday season. Happy New Year. Thank you again for joining us today. And thank you again, Dr. Resnick, for joining us from New York tonight. Have a great night, everybody.